Okay, you guys ready?
Yep.
Okay, who's going first?
Okay, I'll go.
Okay, good.
Okay. So it's like a wedge-shaped biopsy. So it could be a punch.
Yes, it is a punch.
Okay. Uh, it looks like inflammatory, possibly.
Yes.
Okay. Big thing that's sticking out is at the top of the epidermis. There. Oh,
Just trying to figure out how to zoom this thing. It's kind of weird. This is different than on my, I guess I can probably do that. Yeah, I can just use my fingers here. Okay, that's fine. Okay, good. So you think it's an inflammatory process. Okay. Which pattern?
mm. It looks like there's like wedge-shaped thickened collagen bundles.
Okay, so you think the pathology's down here, or you think the pathology up
Well, I think
here?
it's going up in the epidermis, but it's like reacting in the dermis.
Yeah, there's some inflammation in the dermis. And so it's mostly superficial perivascular.
Yeah,
What's going on in the epidermis?
like some thickening.
Well, is that normal epidermis here?
Oh, no, up there. Sorry, you were pointing at the bottom. No, that's not normal.
Okay, what's abnormal about it?
Looks like the stratum corneum's not really present too much.
Yeah, if you look over here, there's kind of no epidermis right there, right?
There's really no epidermis.
What's
Maybe the
going
very
on?
bottom layer. Maybe it was it could be a re-epithelializing if it
Reepithelialized?
like starting to, like if it was sloughed off for some reason. Like it could be starting to grow back at the bottom.
Okay, so what's the main pathologic process here?
Mm. I really can't tell what the left side versus the right, because those two look different. Like, is that how maybe it was before it floated away?
Why did it float away?
Uh, maybe something acantholysis?
Yeah, it's a blister.
Yeah.
So it's an intraepidermal vesicular dermatitis, right? This is a
Mhm.
blister. Now, how do you know that's a real blister?
Is there stuff inside of it?
Yeah, yeah, there's a lot of stuff inside of it. There's serum. There's some other things going on here. And you said acantholysis, but remember the three ways you can get a blister? An
Uh,
intraepidermal blister?
like ballooning degeneration,
Right.
them. Necrosis, I think.
Well, that's not one of the three main ways that you can get an intraepidermal blister.
Oh, traumatic?
Well, we're talking histologic reaction
Oh,
patterns.
okay.
So there's three ones. You said ballooning. You said
Ballooning.
acantholysis earlier. What's the
Yeah.
last one?
Uh, the last one. I think I forgot. Spongiosis?
Yeah, spongiosis. Those are the three main ones. So just start like making sure whenever I say that you can spit it out like you know your phone number.
Okay.
It should be like almost instant when you do that. So you know how to tell those apart, right? You've seen
Yeah.
biopsies of all three of those. So let's
Right.
take a look now and see which one you think it is here.
Mm. So there could be some spongiosis in there.
But do those cells look like they're hugging each other and they're in love and they just really still closely attached to one another?
No, they're pulling apart.
Yeah, they're falling
And
apart.
ballooning?
They're falling apart. Well, ballooning, you'd have fluid inside the cells. Is there a lot of liquid inside those cells?
No. Oh, so it's acantholysis.
Yeah, this is
Oh,
acantholytic.
okay. I was
Intraepidermal
wrong.
acantholytic.
Okay.
Intraepidermal acantholytic. So what group of diseases do you have to think about?
Uh, like the blistering diseases?
Well, that's the overall group, intraepidermal vesicular blistering dermatoses, but which diseases give you acantholysis?
Grovers?
Well, the general, which basic diseases
Acantholytic.
usually give you acantholytic intraepidermal vesicular dermatitis? Grover's can do, it's one of them, but that's not the overall major overarching diseases you need to worry about when you got this degree of acantholysis here.
Uh, like pemphigus,
Yes, the pemphigus group of diseases. Okay. And what are some of those?
Pemphigus vulgaris,
Good.
foliaceous,
Yes. Superficial pemphigus.
vegetans,
I'm sorry, what was the next one?
vegetans.
Yes, that's a variant of Pemphigus vulgaris.
Uh,
And then there's one other one.
Pemphigoid?
No, that's not acantholytic. Remember, that's subepidermal blistering. So that's out. That's not in the pemphigus family.
Okay. Uh,
Which one gives you the dilapidated brick wall, where the entire epidermis is acantholytic
oh,
throughout?
Haley's.
Yes, those are the ones. Then, of course, obviously, perineoplastic pemphigus, but those are the main ones. Superficial pemphigus, foliaceous, fogoselvagium, pemphigus erythematosus. Those are those three. Pemphigus vulgaris, and then Haley disease. Those are the three main ones. Now, if you get into acantholytic dyskeratotic disorders, then you're getting into Grover's, Darier's, those things. So this is more the acantholytic one. So which one is this one most likely to be?
Hmm.
There's the overlying epidermis. Notice that it's not acantholytic way the heck up in the top of it.
Uh, vulgaris.
Yes, this is vulgaris. And see, why did you say vulgaris? You didn't sound too confident
I
about
didn't
that.
sound too confident. Um, well, I was thinking of like the other kinds of the pemphiguses and what those would look like.
Yeah, you should. You should picture those in your mind. So if it's superficial pemphigus, where's the blister going to be?
More superficial,
Yeah,
more.
it's going to be right at the top here. Well, that's not there. It's pretty deep. You got this single layer of cells, the tombstone cells. Remember that when you get single layer? That's just suprabasilar. That's where pemphigus vulgaris happens. And you don't have the acantholysis of the dilapidated brick wall. The whole epidermis is acantholytic. You only have the very suprabasilar part there. So this is going to be pemphigus vulgaris most likely. Sometimes there's some overlap, but this is a nice example of pemphigus vulgaris. And notice how it's tracking down into the follicle right there. Do you see that? That's classic for pemphigus vulgaris. Goes right down the hair follicle. Okay. So make sure you know how to recognize this. If the derm path bowl is coming up in a little over a month, so they might show you that. Make sure you know that one.
All right.
Okay, good. All right, let's do this one.
I can take this one.
Okay.
We're looking at this looks like an excisional biopsy to me. It looks neoplastic.
Do you think it's an excisional?
Yeah.
Why?
It looks pretty large. I mean, it could just be a shave as well.
Yeah, it's probably like somebody took a nice deep saucerization biopsy.
Okay.
Usually excision is going to be kind of like a square, and
Sure.
getting to the fat. So they didn't get to the fat here.
We don't have any fat. Yes. Okay. Well, we have a shave then of
Good.
a neoplastic process.
Good.
Looks like it has. I mean, all I see here are these sort of groups of dark cells that seem to be forming some sort of structure. So I guess from this part's some sort of adnexal tumor.
Okay, so epithelial then, right?
Hmm.
You think of the type of epithelium, you think adnexal. Okay, that's good. Benign or malignant, or you're not sure.
It's tiny. It's pretty well circumscribed from this power. More likely to say benign, but
Yeah, it's kind of hard to tell for sure because we don't have the whole thing. They shaved into it, but if we look at this, it kind of looks like it's got we can kind of find the edge of it over here. So we're going to see, and sometimes these adnexal tumors have an architecture that can kind of look benign, but you go to higher magnification and you can see that it's becoming malignant within it. Okay, so adnexal is a good idea. Let's go to higher magnification. So adnexal, when you say adnexal, what do you kind of mean by that?
well, it's one of the coming from one of the adnexal structures: sebaceous glands, apocrine glands, eccrine glands, hair follicle.
Good, very, very good. Okay, which of those do you favor here?
Mm. This looks more like sweat gland to me.
Good. Why?
It's the shape of the cells, they look, like sebacites, they'd be a little bit more foamy looking. Apocrine cells have the, they're, well, I forget the word, like the apocrine secretion, where they're
Right.
falling apart.
Decapitation, apocrine secretion. That's correct.
Yeah, decapitation, that's right. And then these, they're forming ducts more or less, so they're sort of cuboidal in shape.
Yeah, good. Small, round cuboidal cells. There's some of this has a little bit of a clear staining cytoplasm, but you see that pale cytoplasm in some of those right there? And then,
Yes.
but most of them are small, round, monotonous, boring, clone-like cells. So that's when you think of like eccrine when you see that. That's good. And you do have a duct sitting right there. Very
Mhm.
nice. Okay. So let's look at this other area over here. So generally, what's the name of one of these when it's a benign adnexal neoplasm with eccrine differentiation that's a solid lesion like this? What's the general name that you use for that?
I mean, like a lot of them have like syringo as like their root. Is that what you mean? I'm not really.
Syringo is if you get a lot of ducts. You get lots of
Oh,
ducts, like a
okay.
syringoma. That's syringo. But what do you call when you got what's the other? So syrinx means two. So
Hmm.
it's like that refers to the duct part. What's the stem for sweat?
I don't know, like Hydra, like
Yes, HID,
uh,
HID, not HYD, which is more water. It's like or hydrogen or whatever. That's different. H2O. This is more when you say HID, HID, it means sweat. So if it's got a benign adnexal neoplasm that's made of these of eccrine cells producing American sweat, not African sweat, what is the name of this tumor?
mm, hydradenoma.
Yeah, hidradenoma. Good. This is a hidradenoma. Now, can you say anything more special for a bonus point about this part of it?
Uh, oh, we call it well, I mean, there's space. It almost looks like there's, I don't know if there's erythrocytes, but it looks like it could be, but it could be fluid, so like a hydrocystoma. Could you
Well, it's not exactly, but basically, you may not have heard this yet, but you'll hear it now. This is what we call a solid cystic hidradenoma because it's
oh,
got the solid area over here and it's got the cystic area here. It probably isn't really a cyst. It's probably an area that's just got a big space in it. And that's why we call it solid cystic hidradenoma. It's just a variant of hidradenoma. There's really about 4 or 5 different types of hidradenomas. There's this type. There's the type that we call nodular hidradenoma that doesn't have the cystic component. There's the type where you get, it looks like an eccrine poroma, the cells of a poroma, they look poroid. We call that a poroid hidradenoma. And then there's a clear cell hidradenoma. So those are there's really not a lot of them. So once you get into that category, then you can just add those last few embellishments and then you've got the right answer. Now, one thing that we always have to worry about in these lesions, there's 2 things you have to worry about. Number one, you look to see if there's areas where the lesions are undergoing malignant degeneration in them. so-called hidradenocarcinoma X hidradenoma, coming from a pre-existing hidradenoma. And then you also look to see if it's one of these aggressive digital papillary adenocarcinomas that can simulate hidradenoma when they're on an acral skin site. This is an acral skin site. The other name that we used to call these years ago was ecrine acrospiroma. That's another kind of older name, but this is just an example of a hidradenoma, solid-cystic hidradenoma that happened to be on somebody's hand.
Okay.
Good. Okay. Different category here.
All right, so this one looks like a punch biopsy. And I'm favoring inflammatory.
Good. What part of the body are you on here?
We're on the scalp.
Good.
Let's see.
Why?
Lots of hair follicles.
But you get lots of hair follicles on somebody's back or arm if they're really a hairy person, right?
Mm-hmm.
How about the face? Face can get a lot of hair follicles, like in the beard area.
Yeah, but the oil glands, I believe, are like they're huge around the face and.
Good. They're bigger on the face. That's exactly right. And the follicles usually are not rooted way down in the subcutaneous fat like they are here.
Oh, right.
Good. Okay. So you're on the scalp. Is this a disease or is this just normal scalp? And we're just going to show you an interesting picture of a normal scalp as an unknown.
This is a disease.
Good. Okay. So do you have any idea what disease it might be?
I want to say discoid lupus.
Oh, no.
No? Okay. I retract that. I thought I saw follicular plugging, but that's not what that is up there.
Be careful of using one thing
Yeah.
for a diagnosis. Be cautious of that. The boards love to do that. They'll say, there's follicular plugging, and they're going to think this is lupus. We're going to fool everybody. So beware of that. Well, look at the rest of it though. So you said discoid lupus. So what's the general category of disease we're in here?
Scarring alopecia.
Do you think it's scarring alopecia?
Okay. I thought so.
How about we just step back a little bit and just say alopecia?
Alopecia. Yes.
Okay. So we have to determine whether it's going to be scarring or non-scarring, whether it's going to be permanent or non-permanent, whether there's inflammatory cells or non-inflammatory cells, those kind of things, right?
Mm-hmm.
Okay. Now, so you said scarring. Why did you just instantly say scarring?
I guess because looking at some of the hair follicles, they've turned like pink and
Yeah,
they look
they
like
have
they're not
turned pink.
active anymore.
They have turned pink. Now, there's two ways that a hair follicle can turn pink. One is if it turns to, scar tissue,
Mm-hmm.
and it's totally scarred. The other, if the follicle is shifted from anagen to catagen, and then the epithelium shrinks, and that glassy basal membrane that's around the outer portion of the follicle starts getting thick and corrugated, and it really starts crumpling in, and then the follicle becomes just a teensy tiny little bit of epithelium, and you've got that thick corrugated basal membrane zone in the catagen stage that eventually dissolves, and you just get these little miniaturized telogen follicles.
Oh.
So if you look at this, a little higher magnification, guess what's going on there? You see that big, thick, glassy, corrugated basal membrane zone here?
Mm-hmm.
And there's another one over here. And there's another one over here. And here we've got a follicle that's now in telogen, still a little bit of catagen, shifting into telogen, another telogen follicle. And then look here, around this, we've got a few little sprinkling of some cells here. But we don't need the cells. We don't need the cells. So all of these follicles are being shifted from anagen. They were living happily down here in the subcutaneous fat, getting all sorts of nutrients and everything, and life was good. And then suddenly something happened, and they all got shifted into catagen at the same time. There's really only one disease that'll do that. Usually you'll see little swarms of lymphocytes around the bottom of it, but you don't have to see a lot of lymphocytes, especially if you get it a little bit later than day 2 or 3.
So alopecia areata?
Yes, this is alopecia areata. And I want you to stay at this power a little bit to notice this, because nothing else does this. Nothing else will shift all these follicles into catagen at the same time. This is an immune storm against these follicles, and there were lymphocytes that came in and attacked these follicles all at the same time. They all got shifted into catagen. They shed all this hair at the same time, and boom, we've got this pattern here. And notice there's really no fibroplasia here. These are just follicles that are shifted into catagen and now telogen. And this doesn't happen in telogen effluvium to this degree. You never see this many catagen follicles in telogen effluvium. You might see like 1 or 2. You don't see all this number like this here. And you obviously don't get lymphocytic infiltrate in there. You do have a little bit of residual lymphocytic infiltrate here, but most of the lymphocytic infiltrate's kind of gone away because this is a little bit later lesion. So this is AA. Now, discoid lupus, what's bad for that?
Oh, you probably need like a lichenoid.
Well,
Like
you
a
don't get
vacuolar
lichenoid.
lichenoid, no?
Vacuolar, yes, you get vacuolar alteration. Is the epidermis usually thick or thin?
It'll be thicker.
The epidermis is thin, but the
Oh,
basal
but
membrane zone is thick,
okay.
right? The basal membrane zone is thick, but the epidermis gets thin. Sometimes it's like 1 or 2 little cell layers because it gets atrophic in late stage lesions of PLE. And this isn't really follicular plugging. It's just some cornified material that's just happens to be in the infundibulum that we all have in our hair follicles. And there's no mucin, there's no lymphocytic infiltrate.
Yeah.
So it's got a lot of things that aren't really good for lupus. So this is a great case of one of the forms of AA. Now, this isn't the kind of early form where you see the swarm of bees. The bees have gone. You know, they're no longer in their hive anymore. They're gone. So all we have here is just all the follicles are shifted into catagen. And some now have gone all the way to telogen now. So it's
Dr.
a beautiful
Cockerell,
example of AA. Yes.
can you say one more time, recap about how you can tell they're all in catagen versus anagen versus telogen?
Okay, telogen, these are telogen. These follicles have naturally now they've been shifted into telogen. Little tiny miniaturized follicles, those are telogen up here. These that have the big, thick, glassy basal membrane zones and where the epithelium is dying, that's catagen. Catagen. So that's the thick, glassy basal membrane zone. Another one over here. These follicles are being shifted into catagen. When they get into catagen, that's it. I mean, there's nothing else that'll shift follicles into catagen to this degree other than AA. Okay. Catagen means catabolic. The cells are dying, basal membrane zone is thickening, the cells are shrinking, and they turn into these little teensy tiny telogen follicles here.
All right, thanks. Sounds good.
Okay.
Is it my turn again?
It is.
You guys can fight for terms if you want
I
to.
just wasn't tracking. Okay. This is a shave.
Good.
Looks neoplastic.
Good.
Is it benign or malignant? Not sure. I mean, it's well circumscribed, but it looks scary looking for some reason.
Okay. Why does it look scary looking? That's good. So you noticed it was scary looking.
Yeah.
So your brain looked at this, you applied some criteria. Now you've got to articulate the criteria.
I mean, maybe that means that it's non-epithelial. It doesn't look familiar.
But
There's
it
like
could
the
be
shades.
non-epithelial and not be scary, right?
Yeah. I mean, there's like these
Dermatofibroma,
shades
that's
of
not scary. That didn't
purple
scare
in
us.
there. The shades of purple look scary.
Okay,
And
the purple looks scary. Okay. What else looks kind of scary about it?
like it's denser at the bottom, then it gets like less dense and almost like little islands.
What's that a sign of?
Something not good. Malignancy.
Well, what are the three things we talk about at low magnification? We're deciding whether something's benign or malignant.
Yeah, spongiosis, acantholysis, ballooning.
No, those are the three inflammatory patterns of intraepidermal blistering disease.
Oh, okay.
What about we're looking at a neoplasm and we're going to just the three cardinal architectural features of malignancy in a neoplasm.
Oh,
Why do they look scary?
necrosis. Oh, symmetry.
Yeah,
Okay.
asymmetrical.
Asymmetrical. Well circumscribed. Or
That
not.
means benign or malignant, right?
Yeah.
Which one does that mean if it's well circumscribed?
It's benign if it's well circumscribed. So
Yes.
it's poorly
So what's the
circumscribed.
third one?
then
So this is
more malignant.
ABC, right? ABC.
Borders.
Asymmetrical, broad, poorly circumscribed equals scary.
Yeah,
Malignant.
and size.
Yeah. What about this one? Is this symmetrical?
Pretty big. Kind of like right and left, but not top and bottom.
Yeah, well, this is probably some artifact here, but it may be artifactual because it may be necrotic. You said necrosis, which necrosis on moss tends to go with malignant. But over here, look how it's kind of poorly circumscribed over here. This
Yeah.
piece is bigger than here. So I don't think it's so well circumscribed.
Okay.
I think it's asymmetrical too. And I don't know how big it is, but you know, it does have features that look like it could well be malignant at low magnification. And you
Yeah.
said it looks purple. So that's going to be, you know, what gives you purple at low power? What makes you think of that? Epithelial or non-epithelial?
I mean, normally I think of lymphocytes, but this doesn't really look
Yeah,
like
it could be either one. It could be either one. Could be lymphocytes. Let's go to higher magnification, see if we see anything that kind of gives us a clue. Can you tell now?
They're really densely packed cells.
Right. They're blue.
They're blue. I
You think they're epithelial?
think it's non-epithelial.
You think it's non-epithelial? What
You
about
got
these
these,
white
like-
cells?
Yeah, you got
What
these
about
like
these?
foamy looking cells.
You know, what are those? What cells gives you little bubbles like that inside their cells like this? With these little strings of nucleoplasm. Looks like a little star there, kind of.
Stellate?
What kind of cells give you this pattern?
Oh, I want to say they're from the lung. That's sebocytes? Sebocytes?
Yes, these are sebocytes. Sebocytes. Fix this in your brain, okay? If you see this bubbly material and you got these little radiating kind of gossamer strands of nucleoplasm and cytoplasm coming from the nucleus like this, sebaceous.
Oh, so then it is epithelial.
Yeah. Yes. What's the purple part?
Like the stroma?
No.
No?
Think about a sebaceous gland.
Yeah.
What are the two main components of a sebaceous gland?
The duct?
Okay, there is a duct, but that's not really the gland, right? I mean, that's kind of the,
I guess is where the gland kind of goes.
what
It
about the
produces,
glandular component that empties into the duct?
like it's kind of like the follicle of it. Is that
Well,
what's it
you've got two things that comprise that glandular component. One is this, right? The mature sebocytes. What
Okay.
else is there? What's on the outside of that, with the very outer rim of the sebaceous gland?
The lining?
What is the lining of it? What comprises the lining? Is it possibly these?
Yeah, those cells.
What are those cells?
What are those cells? What are those cells?
Yeah, what cells kind of live and they produce glandular tissue like this and whatnot. They also tend to live down in this area too, although that's not obviously a gland. Here's a little area of it right here. You think these cells are turning over rapidly, or you think they're just kind of slowly maturing and they're not really growing very quickly?
I think they're growing really quickly.
So what do you
There's
call
plenty
those
of
cells?
them. They're really dense.
And what do you call these cells?
Hyperplasia?
What's that?
Like hyperplasia?
No, well, they're neoplastic, actually. They're not hyperplastic, they're
Yeah.
neoplastic. But these are the type of cells, they've got a name to them. So you've got the mature sebacites, and then you've got the germinative cells. These cells are the stem cells that make these cells, okay?
Matrix?
Well, these are the stem cells of the sebaceous
cells.
gland. And these are the germinative cells of the sebaceous gland. So if you look at a normal sebaceous gland, you've got a few tiny little layers at the very outer edge. You hardly see them on routine staining of a regular sebaceous gland. In a cancer or a neoplasm, those things go haywire. They produce, you know, there are way too many of these. So what's the diagnosis here?
So we have a malignant.
Yeah.
sebaceous-
So what's the name? What's that called?
Sebaceous carcinoma?
Yeah, this is sebaceous carcinoma.
Oh, there we go.
Yeah.
Put the words together.
Okay. So usually those are comprised of mostly these cells with some of these. If they're very well differentiated, you may get more of those, but they all virtually all have lots of these cells. And you need the architectural features, you need necrosis en masse, you need mitotic features, you need all those various things to call this cancer, because if you get a benign sebaceous lesion, like a sebaceous adenoma or a sebaceoma, those don't have those features. They're smaller, they're symmetrical, they may have mitotic figures, but they don't have all these other features like this lesion has. It's very asymmetrical and it's got this necrosis en masse and this hemorrhage into the lesion. So you don't want to overcall those as cancer when they're just basically have the stem cells that are causing the lesion. Okay. So these are basically the same kind of stem cells that make your hair follicle. So you're going to expect there to be some mitotic figures. They're going to be bipolar mitoses. You know, you're not going to usually see a lot of very bizarre, atypical mitotic figures in a benign lesion, but you are going to see mitoses in a benign sebaceoma. Okay. Got it?
Got it.
Okay.
Okay, this time we have another shave.
Right.
Yeah, and it looks like a neoplastic process. There appears to be well, there's like this central core. I don't know if we're looking at a hair follicle here.
Yeah, you are looking at a hair follicle, actually.
Bizarre
Remember we
looking.
talked about this last week?
Oh,
We talked about this phenomenon last week.
kind of. I don't remember the name, but
Okay, look at it. What does this look like to you?
it looks like there's a buildup of material in the
Right.
hair follicle.
Is this okay? So let's look over here. It is a follicle, right? Here's a hair follicle right here for sure.
Yeah.
What about that cornified layer?
Well, it's thickened.
So what can you say about this specific biopsy lesion right here based on that?
Oh, like picking, scratching.
Yeah, yes. Has to be picked. Has to be rough. And what did we say last week in our non-unknown session? When you get picking and scratching and you get this kind of phenomenon right here.
Right. Perforating.
Yes, good. This is a perforating condition. Something is trying to be, extruded out of this area. Patient says, something's in my skin. I don't like it. I'm going to pick at it. And they start picking at it. So we talked about elastosis perforans serpiginosa, talked about Curley's disease. We talked about reactive perforating collagenoses, how they're all basically the same process. But what's getting transepidermally eliminated and perforating this time? You should know this for sure.
Because of this red area down here.
Yeah, what is that red area?
Looks more, this is elastin, I think, elastic fibers.
Well, if you're looking here, it's kind of got some hyaluronic acid. It's got these little cells in here with little lacunae and spaces around them. And if you look out in this area, it's got these round cells that are probably remodeling this thing here. See the little clefts around these little nuclei here? It's pink.
Yeah, so it could be like some sort of osseous material.
Yeah, this is osteoid. This is bone. This is a small bit of bone in the skin, and it's basically Osteoma Cutis. Osteoma Cutis. So any orthopedic surgeon that's worth his salt should know bone formation in the skin, right?
Of course. No, I don't think that was in our reading though. When we talked.
It may not. These are unknown slides here, by the way, guys. This isn't thematic today, so these are unknowns.
Yeah.
So this may not have been in your reading yet, but this is basically what bone looks like in the skin. And what happens here, there's two ways that this can happen. One is you can shave into like an osteochondroma or bone spur. This wasn't the case here. The other is if you've had like some kind of a prior traumatic injury and you get secondary bone formation that just happens, it's called osseous metaplasia that occurs in the skin. The most common setting that happens is people that have acne and they get, late stage burned out acne and they get acne scarring and they get chronic inflammation and secondary bone formation, these little tiny sort of slightly purplish lesions on their face. And they say, these look purple. I don't like them. And you go in and you like say, well, we'll take a biopsy of one. You're going to, you feel, it feels like you're putting it into gravel because there's bone that's there. And you do a biopsy, it looks like this. It's really slightly unusual for them to be transepidermally eliminated here. That's just kind of an interesting phenomenon of this case. So it's kind of good to kind of review that perforating business we talked about last week. But this just shows anything can be perforated that's in the skin that doesn't belong there. It's just another way of the host getting rid of something. So this time it's getting rid of the bone that got formed there. Other times it might be a splinter. It might even be a deep fungal grain that might develop. Okay.
Dr. Cockerell, I did want to say one thing. I don't know if we covered it last week, but because our lecture last week was on a lot of deposit type stuff.
It might have been 2 weeks ago that we talked about perforating.
No, well, because we missed we missed a week and then we made up for it, but I don't think we covered last week's lecture, which was like deposits like amyloid and xanthelasma, xanthomas, that sort of thing.
I think we will cover that. We need to get that. Chris will pull that together and we'll go over that also.
Okay. Sounds good.
We ain't gonna miss anything.
Okay.
Okay, so we have a shave biopsy.
Okay.
It's inflammatory.
Good.
And it looks like it's happening intraepidermally.
Good.
Looks like a blister.
Good. So you're right where Marissa was a couple of slides ago. So we got the same differential.
Yes.
Right? All right,
yes.
So we know the 3 ways of getting blisters, right?
Yep.
3 main ways. Okay. Which way are we looking at here?
Ballooning?
There is some ballooning. You're right. There is some ballooning.
It
Over
looks
here.
mostly acantholytic though.
There's acantholysis and ballooning this time. So we get a twofer.
Fun.
A twofer. When you see ballooning, what do you generally think of?
Virus.
Yes, usually think of viruses. Are you aware of any virus that causes both ballooning and acantholysis?
Not at the top of my head, but maybe HSV.
That's pretty high at the top of your head. Yeah, it's the first thing that came to your mind. It is the top of your head. So you said HSV. Do we have to say HSV or can we just say H?
H works.
H works because we can't tell the difference between HSV 1, 2, and zoster. They
Yep.
all look the same, right?
Yep.
Okay. Is that what this is?
Trying to look for giants, like multinucleated giant cells. Yeah.
Is that one of those?
Yeah.
So we are dealing with herpes, right?
Mm-hmm.
Good. Here's another. Now, these are kind of the earlier cells before they form multinucleated cells. They're still virally infected. These are the Cowdrey bodies.
Oh, okay.
See those little pink sort of hyaline-like structures? I'm not sure anybody really uses that much anymore today, so you don't really, they're not going to ask you that on the exam. They better not anyway. But notice the margination of the chromatin.
Mm-hmm.
That means the chromatin gets at the outer edge of the nucleus here, and they get purple and smudged. That's all the ballooning degeneration. So this is herpes infection. Good. And notice how different it looks in the pemphigus case.
Yeah.
Pemphigus is also acantholysis, but that didn't have any viral cytopathic effect. So you got to be able to recognize that viral cytopathic effect. You will see this on the exam. You will see this in some form on the exam. You'll probably get half a dozen questions about it. Therapy, is it associated with underlying diseases? You know, all sorts of good questions. They show you a pathology of it, might show you a zinc prep of it. So you're going to get this. So be prepared. It's like a Boy Scout, right?
Yeah,
Get a
so
pretty dense.
these giant cells are just like keratin cells that have clumped together.
These are individual keratinocytes that have multiple nuclei in them. Multiple nuclei.
Oh, okay.
Multinucleated giant cells. Okay, the virus causes proliferation of all that DNA inside the cells, and it's making so much of it, it makes more than one nucleus.
Gotcha. Okay, that makes sense.
So that's how it works.
Okay.
Okay. Another one for Dr. Seresny here, I think.
All right, so this is
Are
really
you as
small.
unhappy about the result this weekend as I was? I was so pulling
Oh, I
for
know.
you
I really
guys.
wanted the Lions to win.
I'm
They were
really
doing
very
so well in
angry
the
with your
first half.
coach. I'm not happy with your coach. I think he made some very bad decisions.
I know. I think he should have done the field
Field
goal.
goals, yes. It's one thing to use analytics when you're playing the Washington Commanders. It's another thing to use analytics when you're playing the San Francisco 49ers, the best team in the league.
Yeah,
You
very
don't go
sweet.
4th and 3 against them. Sorry. I was really very sad.
Yeah, I know. Everyone's sad. All my patients have been sad too that I've talked to this week so far.
I don't blame them. I
Yeah.
almost felt as bad for them a little bit as I did for the stupid Cowboys. I didn't feel bad for them. I was angry at them. Felt
Yeah.
bad for you guys.
Well, at least it's been the best season in many, many, many years.
Yeah, you get that close to going to the final game and you blow it because your coach makes bad calls. That's a shame.
Yeah, it's a shame.
But
Yeah.
anyway, you get to do pathology now.
So this is a really small shave.
I think it might even be
Well,
a
maybe it's
punch.
actually, no, it's a little deep, so maybe it's a little punch.
Yeah, you know, they fell in love with the biopsy. They liked it so much they took their tweezers and just squeezed it here, unfortunately.
Oh,
We don't
okay.
like that. When you do a punch and you're pulling it out from the skin, you should take your needle and just kind of tease it out or push it out like you're pushing out a zit or something, but don't squeeze it. They're lucky that there wasn't pathology down here. We wouldn't be able to evaluate it.
Yeah, it's likely not something that was like really thick though, because probably wouldn't have done that.
You'd be surprised.
Oh, okay.
All right, so what are we looking at here?
Okay, so it looks like the action is like right under the very thin epidermis.
Yes, it is. So what kind of action are we looking at?
So another kind of intraepidermal blister, or maybe subepidermal.
Okay, I will agree. I think it's beneath the epidermis. Okay, we're going to talk about that. This is an interesting, relatively, it's an unusual type of blister. So is it inflammatory?
Yeah, but like not very.
Good. It's got a sparse inflammatory infiltrate of mostly what kind of cells here?
Some neutrophils,
Why neutrophils?
because they're dark, or maybe
What's what
lymphocytes.
you meant lymphocyte? I knew that's what you really meant.
Yeah, that's what
Okay.
I really meant.
Now there is some blister that's formed here. I will agree with that, and I think it's a real blister. There's material in that space there. Is there anything else that you can see at low power?
Yeah, there's this pink
Yeah,
material, very
pink. Yeah, bubblegumish pink. Different than this reticular dermal collagen here, different than these erector pili muscle pink.
right.
Square magnification a little bit here. Now let's look at it.
Okay, so it looks like it could be like degenerated. It's got this like smooth appearance to it with like the
Yeah.
wavy things. Yeah.
What do you call that appearance? This has two different pathologic processes going on in the same exact field here. And actually, interestingly enough, we look down here, guess what some of these cells are other than lymphocytes here?
EOS?
Actually, no.
No?
No EOs. See that cell that's got that kind of clock-faced nucleus and a little bit of
Oh,
paranuclear
plasma
halo?
cell?
Yes, plasma cells and lymphocytes, but there are actually quite a few plasma cells. But let's go back to this material. So where are we here? Here's the epidermis. What's just beneath the epidermis?
Is that like collagen?
Well, it is collagen, but what do we call that collagen?
That was
What's the anatomical structure we're looking at here?
like, I don't know the right term for it. Like hyalinized?
Well, it is hyalinized, but what is hyalinized? What's being hyalinized here?
The
Here's the stratum
fi-
corneum, epidermis, blank, blank. What's this down here called?
the reticular dermis?
Yeah, so what's this called?
Papillary dermis?
Papillodermis, good. They said it's hyalinized. What do we mean when we say hyalinized?
Like it looks
What's
like
this?
a
What's
cartilage.
another thing that's you could call this here besides just hyalinized? Is there an increase or a decrease in the number of fibroblasts?
Decrease?
Decreased. Now there's collagen bundles in the papillary dermis. It's looser connective tissue than the reticular dermis. Type 1, type 3 collagen down here. This is looser collagen up here. Reticular fibers, and it's a delicate. So if you get a decrease in fibroblasts and the fibers that are there are homogenized, what do we call that term? What's that called? Homogenization of collagen bundles, decrease in fibroblasts. What's that pathologic process known as?
Is it sclerosis?
Yes, sclerosis. If the papillary dermis is sclerotic, It's also, why do you think it looks white like this? Why do you think we have a blister? There is a real blister here.
Weak
What's
and
that?
broke apart. It was weak and broke apart.
That's part of it. But it's also edematous, markedly swollen, edematous. There's fluid in here. Okay. So what's the diagnosis?
Good question.
What do you think it looked like clinically?
A blister?
It probably was a blister, but what do you think the background skin looked like? Let's have a look at the other piece.
Yeah.
That isn't a blister. Okay, so it's the same process here, just different stage of evolution. See it here? It's the same thing. It's just not as florid as the other one. So what do you think this looks like?
Pink and shiny, maybe?
Well, if it's sclerotic,
Like indurated?
it might be a little bit indurated, but it might be kind of atrophic.
Oh,
The
atrophic.
epidermis is thin. There's no epidermal reedy anymore. The papillary dermis in the other section was edematous. It did form a blister. So because there's loss of integrity of that papillary dermis, it doesn't have the same tensile strength as it used to. So it just kind of formed a blister. That's a dermal blister, by the way. That's not subepidermal. It's an intradermal blister in this case. So we said this collagen was sclerotic in the papillary dermis only, with edema that resulted in a secondary blister. What's the diagnosis?
Could be lipodermatosclerosis.
Well, where's the pathology in that condition?
Well, that's not where I think it is.
Well,
Is it
what do
dermis?
those patients look like? What do they look like clinically, those patients?
Like on the legs.
Yeah, they look like an inverted champagne bottle.
Yeah.
It's due to chronic stasis dermatitis, and it's in the subcutaneous fat.
So we would
So they
probably
have-
see more like iron in the skin too for the color.
You don't have to, but you might. But basically, that's a paniculitis. Well, this isn't a paniculitis. This is involving the papillary dermis, so it would never be that. But what gives you sclerotic papillary dermal collagen like this?
Morphia?
That usually involves the reticular dermis. Here we're involving only the papillary dermis. So if you went up and saw this patient, this is going to be atrophic, probably be white in
Like
color.
lichen sclerosis?
Yes, this is lichen sclerosus atrophicus.
Oh, this has gotten me before.
Okay, well, it hopefully won't get you again.
Yeah,
because this
wait,
is
the
the
blister
classic.
threw me off.
But you can get bullous LSNA.
Oh,
You get bullous LSNA because of the fact that you get the marked papillodermal edema, like here.
okay.
You're going to see this in patients. They're going to come in with a white area on their genital area, and then they'll have these hemorrhagic blisters that occur in those areas. They can be eroded like this. So this is LSNA that formed a blister because of all the edema and the loss of the turgor, loss of the structure of the collagen in the papillodermis.
Okay.
Floated away. Got it?
Got it.
All right, you gonna do one more before we
Okay.
go? Since we started.
Sure, quick. We can do one quick.
Okay. This is a great case, by the way. It's beautiful, gorgeous.
All right, so punch biopsy with mostly deep, like perivascular or periadnexal inflammatory cells, lymphocytes, but then below
Good.
that, like the fat also is bizarre as well. There's looks like there's some sclerosis amongst the fat, or it's replaced by some sort of tissue.
Okay, good. So we're dealing with a what in this area?
Paniculitis,
Good. Pattern of paniculitis.
lobular.
Lobular. Vasculitis or no vasculitis?
Mm, well, I do see like perivascular. I don't know. I can't really tell if there's
Okay, yeah, we're not sure, but we sure don't see like a large blood vessel down here that's got inflammatory cells in or anything like that. So probably no vasculitis. But we do have a lot of lymphocytic infiltrate superficially, which is important. And if you're lobular, higher magnification, almost purely lobular, what's going on right here?
Uh, there's some white space between the.
Those white spaces are the fat microcysts. But what about this here? This is the key.
Oh, well, I referred to it as like sclerosis, but maybe it's, I don't know, could be some mucin too.
There probably is some mucin over here. There's definitely some mucin, but this is hyaline degeneration of the fat. Hyaline degeneration of the fat that's diffuse lobular with lymphocytic infiltrate atop. So what's the most likely diagnosis?
Okay. Can we have, well, wait, can you say that it was lobular, where, what was it called? What was it called between the adipocytes again?
Hyaline degeneration of the fat, diffuse lobular paniculitis with no vasculitis, and an infiltrate of lymphocytes overlying it, nodular lymphocytic infiltrate.
Yeah.
Follicular also.
Okay.
And if we look real high magnification, I don't see much here, but you often will see there's a little bit of smudging in the dermatodermal junction here, probably.
Okay.
See it? So what's the diagnosis?
Smudging. Lupus paniculitis.
Yes, this is lupus paniculitis. It's gorgeous, beautiful, pathognomonic. If they show you if they're going to show you this on the exam, this is the kind of biopsy you're going to get. It's got everything you want to see. So it's got this lobular paniculitis, hyaline degeneration, sclerosis of the fat, lymphocytic infiltrate. 65% of these patients have systemic lupus erythematosus. You almost always get changes of lupus erythematosus overlying the paniculitis. So it's not just purely paniculitis. You'll get changes of lupus overlying. And here you've got mostly kind of a tumid LE pattern overlying it. And you'll often see some interface change. There may be a little smudging in the D junction here. It's not great, but you don't have to have it. But it's kind of suggestive here. Certainly the lymphocytic infiltrate is impressive here. So great. This is a great example of lupus paniculitis. So fix this in your brain also. Okay.
Sure.
All right. So we'll do the clinical session tomorrow, regular time.
Okay. Like Kodachromes or?
Yeah.
Gotcha.
All right. We'll see you guys tomorrow.
All right. Sounds good.
Bye.
Bye.
See
Thank
ya.
you.
You bet.